Once a year, on the same Tuesday in March, a senior community urologist schedules one open radical prostatectomy on his block. He is 61 years old. He has done somewhere north of 2,000 robotic prostatectomies in his career. He could send this case to the surgery center an hour east. They would do it robotically by Thursday. He doesn't. He does the open case because his hands need it. He has watched what happens to the urologists who let them stop working. He watched it happen to two of his partners 10 years ago. He watched it almost happen to himself once on a Tuesday in March, 12 years before this one. The case takes him 3 hours and 20 minutes. The patient is fine. He will not do another open case until next March. Level 1, the intern. $66,000 a year. The match is in M3, not M4. Urology pulls forward by a full year. Applications open in the summer of your third year of medical school, interviews come in the fall, rank lists go in by January, and you find out where you matched before most of your classmates have started writing personal statements. A little over 400 PGY1 urology slots open in the country each year. You took one of them. The first thing that happens after the match is that you discover the first year of your urology residency is not urology. It is general surgery internship. You wear the general surgery ID badge. You scrub on gallbladders and appendectomies and trauma cases. The closest you come to your specialty in 12 months is a half day a month on the urology service, if your program is generous about it. The hours are general surgery hours, 5 a.m. alarm, pre-round on 3 or 4 post-op patients before table rounds at 6:30. Pager attached to scrubs. The day owned by floor work. Drains, discharges, family meetings the senior wants to skip. 3 a.m. on a Tuesday in October, the general surgery pager goes off and the page is from the ED. 16-year-old male, sudden testicular pain, vomiting. 3 hours from symptom onset. The ED is asking for urology. The urology senior is 20 minutes out from the hospital. You are the closest person in the building with a urology badge, and you are an intern, which means you are not the one operating. You walk to the ED at a faster pace than you would admit to. The patient is curled on the gurney. The window for salvage on a torn testicle is 6 hours. You start consent. You get the OR booked. The senior arrives, scrubs in 12 minutes later, detorses the testicle, fixes both sides. The patient is fine. You walk back to the floor at 4:20 a.m. and write the post-op note. The note takes you 18 minutes. The senior is already home asleep. 12 months from now, you will be the junior who scrubs in. Level 2, the junior resident. $70,000 a year. The badge changes on July 1st. You are now a urology resident, not a general surgery intern with a future. The AUA in-service examination is every February, and the score follows you through the rest of your training. Programs read it, fellowship committees read it. You start studying for the next one in March of this one. 4:45 a.m., cystoscopy clinic, 3 half days a week. The OR 3 days a week. Stone call on a rotating block that ends approximately when you stop being able to tell what day it is. The OR cases come fast. First, ureteroscopy with laser lithotripsy as the primary surgeon. A 41-year-old plumber with a 4mm stone wedged at the ureterovesical junction. You pass the scope, find the stone, fire the holmium laser, fragment it into pieces small enough to basket out, and place a JJ stent. The attending sits in the corner with her arms crossed. 42 minutes total operative time. First, TURP, transurethral resection of the prostate, on a retired 73-year-old schoolteacher with severe BPH. The attending stands behind you. You drive the resectoscope. Cuts come off in chips. The prostate opens up. First time scrubbing a robotic radical prostatectomy. The attending is at the console across the room. The screen is 2 inches from his eyes. His hands are on a pair of master controllers. The 4 robotic arms inside the patient's pelvis move when his hands move. You are at the bedside in a sterile gown, holding the camera arm. An hour passes. 2 more will follow before the case is done. 90 minutes in, you realize the operation is happening across the room. You are scrubbed in for someone else's case. The stone call hits between OR days. 3:30 a.m. on a Wednesday. Obstructing ureteral stone, the patient septic in the ED, blood pressure dropping. You drive in. You stent him at 4:20 a.m. You are back in clinic at 7. By the end of the month, you have done 41 of these. The cystoscopy clinic mornings start to blur. 18 patients between 7 a.m. and noon, local anesthetic, a flexible scope. 90 seconds inside the bladder, a 30-second conversation about what you saw. By the third month, you stop noticing the motion. The OR booking sheet outside the lounge has your name on 3 lines this week. None of them involve a console. 2 more years. Level 3, the chief resident. $80,000 a year, PGY 5. The AUA case log minimums are met. The in-service score from February is the highest you have ever gotten. The ABU qualifying examination, the written board, is in the spring, and you are studying for it on call nights with the textbook across the keyboard. The chief year has a shape too. 4:30 a.m. You round on the service census before the juniors arrive. You set the day. You make the OR assignments. The pager comes to you first, the attending second. 3 to 4 OR days a week. Call once a week. First, robotic-assisted radical prostatectomy at the console as the primary surgeon. A 61-year-old patient, Gleason 7, organ confined, 3 hours, 20 minutes from skin to skin. The attending is at the bedside, holding the camera arm, not at the console. The blue glow of the console face is 2 inches from your eyes. The robotic arms move when you move the masters. The seminal vesicles come up. The neurovascular bundles drop away. The prostate comes free. First partial nephrectomy at the console the following month. A 3-centimeter exophytic renal mass on a 48-year-old. Clamp the renal artery, excise the tumor with a margin, renorrhaphy in 2 layers, unclamp. Warm ischemia, time on the dictation, 19 minutes. Vasectomy clinic on Friday afternoon. 4 cases between 1 p.m. and 4 p.m. No scalpel technique, in and out of each room in 35 minutes. You realize, somewhere between the 3rd and the 4th, that you are good at this. November of chief year arrives. Most of your co-chiefs are interviewing for community group jobs. They sign letters of intent in cities they grew up in. A handful of you are filling out fellowship applications. Uro-oncology and urology, female pelvic medicine, PD's urology. The choice happens earlier and more quietly than it does in general surgery. There is no match day reveal for the direct-to-practice path. People just stop interviewing. You have 30 days to decide. Both paths pay. The difference shows up in the console. You arrive an hour early to the OR the morning after your first console case. You sit at the masters with the system powered down and run through the steps of the case in your head. The chief who came before you used to do the same thing. The chief is gone. The chair is yours. Level 4, the fork. $400,000 to $550,000 a year. About 30% of urology graduates do a fellowship. In general surgery, the number is 80%, same training length. Opposite default, in urology, direct-to-practice is the majority path. 2 of your co-chiefs sit at adjacent computers in the resident workroom on a Wednesday afternoon in November. One is finishing a Society of Urologic Oncology fellowship application. The other is reviewing a letter of intent from a community group 3 states away. They graduate the same Tuesday in June. Path A, the academic urologic oncologist. The fellowship is 2 more years. You walk into the University Medical Center on July 1st as the most junior faculty member of the GU Oncology Group. 1 service. Tumor board on Wednesday mornings, multidisciplinary clinic on Tuesdays, operating Mondays, Thursdays, and Fridays. Representative week. Monday, robotic radical prostatectomy, robotic partial nephrectomy, both at the console. Tuesday, robotic radical cystectomy with intracorporeal ileal conduit, 8 hours in the room. Wednesday, tumor board, then a robotic prostatectomy. Thursday, open radical cystectomy on a patient with 4 prior pelvic surgeries and a hostile abdomen, one of the last open cases on your block this quarter. The console is your daily tool. The same 5 operations come around next Monday. Path B, the community generalist. The other path starts the same Tuesday in June and looks nothing like the first one. 7 a.m., 12-minute drive to the surgery center. Clinic, Monday and Wednesday. OR Tuesday and Thursday. Vasectomy, half-day Friday. Stone call 1 weekend in 4. The county hospital, 40 minutes east, is yours on those weekends too. Tuesday, OR, a ureteroscopy on the Friday night stone patient, a TURP on a 78-year-old with retention, a vasectomy reversal on a 36-year-old who remarried. Thursday, a robotic radical prostatectomy at the surgery center on the group's leased robot scheduled around the bariatric block. Friday afternoon, 4 vasectomies between 1 p.m. and 4 p.m. local anesthetic. You are in and out of each room in 28 minutes. The kid sitting next to you at the in-service exam 2 years ago is out-earning the academic chair who taught you both. The academic uro-oncologist sheet on Tuesday. 4 robotic cases. All GU oncology, same arrangement next Tuesday. The community generalists that same Tuesday. A cystoscopy, a TURP, a ureteroscopy, a vasectomy reversal, a robotic prostatectomy. 5 different operations, one day. Both surgeons spend their best operating hours at the console. They are the post-robot generation. Neither will do as much open surgery as the seniors who trained them. 5 years pass. Level 5, the early attending. $520,000 a year early attending. The ABU certifying examination, the oral board, comes at the end of fellowship or in your second year of practice. The QE plus the CE makes you board certified for the first 10-year cycle. 6 a.m., 2 OR days, 2 clinic days, 1 half-day vasectomy block on Friday. Tumor board Wednesday morning if you are academic, bariatric block coordination if you are community. Stone call, 1 weekend in 4+ pager coverage 2 weeknights a week. The first complication arrives on a Wednesday. You did a robotic radical prostatectomy on Monday for a Gleason 7 patient. Clean operative dictation. Post-operative day 5, the patient is in the ED with rising creatinine and a drain output that has changed character. The CT shows a urine leak at the vesicourethral anastomosis. At 2 a.m., you take him back to the OR. The anastomosis comes down. You redo it under direct vision, place a larger Foley, leave a pelvic drain. The case has your name on it. There is no fellow above you, no senior attending taking the call. The decision was yours at 1 a.m. in the ED, and the operation was yours at 2:30 a.m. in the OR. M&M conference the following Wednesday at 7 a.m. Your case on the board. 2 of the partners in the room trained you. You present. The discussion is short and real. 4 a.m. on a Friday, the stone page, obstructing left ureter, septic patient. You drive in, you stent him at 5:15 a.m. You are back in clinic at 7. You have done this once every 2 weeks for 5 years. There is a backup pair of scrubs in the bottom drawer of your office desk. You stop describing this part of the job to your spouse around year 3 because there was nothing new to describe. 6 a.m. at the console. The way the chief who trained you used to do it. You have not thought about her in years. The last open radical prostatectomy you did as the primary surgeon was as a chief resident. You have not noticed. 5 more years. Level 6, the mid-career attending. $600,000 a year mid-career. The ABU continuous certification cycle runs every 10 years. You pass your first one. The practice is built. Partners have been hired beneath you. You are training the fellow now or the new associate. 6:30 a.m., same drive, same coffee, same console. The academic mid-career week is 4 operations on rotation: robotic prostatectomy, robotic partial nephrectomy, robotic radical nephrectomy, robotic cystectomy, the same 4 for 10 years. The community week is the mixed schedule from year 1, except the 4 vasectomies on Friday have become 6, and the stone call has been distributed across 3 partners and the new associate. A Tuesday morning in March, robotic radical prostatectomy on a 63-year-old. Steep Trendelenburg, 4 ports, robot docked, the case clean for 28 minutes. The Da Vinci throws a critical fault on arm 3. The console screen goes dark. The bedside team starts the conversion protocol the way the rep walked them through it during the last in-service. The patient is stable. The pelvis is partially dissected. You have a decision to make in under 60 seconds. You scrub in at the bedside. The last open radical prostatectomy you did as the primary surgeon was 8 years ago as a chief resident. You had done 7 of them across residency. Your hands remember the first 2 layers: the retropubic exposure, the endopelvic fascia incision, and then stall on the dorsal venous complex. You call the senior partner from the office across the hall. He scrubs in beside you 90 seconds later. He has been doing this operation since the year before the first Da Vinci was approved for prostatectomy. He ligates the dorsal venous complex with a deep figure 8 stitch that your hands do not know. The case finishes 48 minutes from the moment you converted. The patient is fine. The conversation in the surgeon's lounge afterwards is short. 3 of the partners standing there have done what you just did. The other 2 have not done an open radical prostatectomy in 12 years. The console gave you 10,000 hours of motion in 4 ports and took something else in exchange. The senior partner who walked in to finish your case knew the trade was happening. He had watched it happen to 2 of his partners 10 years before. 10 more years. Level 7, the Endgame. $800,000 to $1.2 million a year, the Endgame. 2 Endgames in the same specialty. Endgame A, the department chair. Section chief at year 10, vice chair at year 15, chair at year 20. AUA Leadership Committee, SUO Board, visiting professorships at 3 institutions. Operate Mondays only, M&M Wednesday at 7 a.m. You run the room now. Hire junior faculty on Tuesday afternoons. AUA committee calls on Thursdays, grand rounds Fridays. 1 robotic radical cystectomy on Monday morning with the fellow on the bedside and the chief resident at the console. You sit in the corner. You have not done a TURP in 7 years. You have not seen a vasectomy in 12. You have not held a scalpel for an open case in 9. Endgame B, the senior community partner. 25 years in the same group, the same town, the same call group, smaller now, the same surgery center, the same scrub nurse for 16 years. 6 a.m., the 12-minute drive, clinic Monday, OR Tuesday, clinic Wednesday, OR Thursday, vasectomy block Friday. The Friday vasectomy block has been 6 cases on the same schedule for 16 years. A Thursday afternoon in late October, a 44-year-old patient drives 90 miles to your clinic for a vasectomy reversal. The closest urologist to her husband's hometown is 200 miles east. She tells you they tried for 2 years before they found you. You do the case the following Tuesday. 62% of U.S. counties have no urologist. The population that needs them has aged into the diagnoses that put them in your clinic. The pipeline behind you has not closed the gap. Behind you, the counties stay empty. You schedule 1 open radical prostatectomy on your block every March, the same Tuesday every year. The way other people schedule a physical, you do it by choice. Your hands need it. The conversion case from year 9 taught you what happens to the surgeons who do not keep them working. The senior partner who walked in to finish that case 20 years ago is retired now. You took his March block. In front of you, the console is locked up overnight, the blue glow off, until 6 a.m. tomorrow. In 2 days, you will be at the open table with the patient who has been waiting for next March. 2 urology residents at adjacent sinks in a hospital scrub room on a Tuesday morning in July. Each of them is washing for their first case ever, a ureteroscopy with laser lithotripsy on the first stone of the morning. The OR booking sheet behind them lists 11 cases for the day. Neither of them can read it yet. In 20 years, one of them will run an academic GU oncology service and operate 1 Monday a week. The other will do 6 vasectomies on a Friday afternoon in a town the first one has never heard of. 3 years from today, they will scrub for their first robotic prostatectomies on the same Tuesday in March. One of them will sit at the console. The other will hold the camera arm at the bedside. They will switch the following week. 25 years from today, one of them will schedule 1 open radical prostatectomy on his block every March, the same Tuesday every year. That is when the trade begins.